stepped out. She will not be here today. And first item of business, I have a request for bill introductions. Anybody have a bill that they want to introduce? Seeing none, okay. Well, the first thing, I guess, Matt, are you up? Okay. Matt's going to give us a summary of the recommendations from the 2021 Special Committee on Home and Community-Based Services and Developmental Disability Waiver. That was a proviso that was in last year's budget that came out of this committee to try to study that and see what our options were. So take it away, Matt.
Good afternoon, Mr. Chair, members of the committee. My name is Matthew Moore, fiscal analyst with Legislative Research. I just wanted to provide a quick overview. You should have a copy of the special committee report in front of you. Really, I'm just going to touch upon the first few pages. We met over the interim for 2 days in October to kind of review some issues on the IDD waiver. We heard testimony from the agency as well as some stakeholder organizations, some individual families that have people on the wait list, as well as some providers of IDD waiver services. Ultimately, the committee came up with 10 recommendations that are on page 3 and page 4 in that gray box. I'm not going to go into each one individually, but just wanted to kind of touch upon the broad themes that each one sort of represented. There were 3 sort of categories, I would say, each of the recommendations sort of fell into. The first being further study on the IDD waiver, funding for the IDD waiver, and then some review of the sort of structure of the waiver. To touch upon sort of that study element, the committee, the first recommendation that they made was that the LCC consider approval of a task force or special committee similar in structure to the 2020 and 2021 Mental Health Modernization Committee. So that would be the committee that's met the last 2 interims, has working groups looking at the mental health system in Kansas. They had suggested that we have a similar committee for modernization of the IDD waiver. The next one I'd like to touch upon that sort of dealt with studying of the waiver is that 4th one, that KDADs conduct kind of an analysis of the targeted case management services and what those rates are on the IDD waiver, and sort of compare them to the STEPS program and KDHE, and then provide that sort of analysis to this committee as well as the counterpart on Senate Ways and Means. The next one is the second from the bottom, that KDAD sort of with KDHE provide some sort of a analysis of individuals on the wait list currently, kind of reassess. Throughout the committee, there was testimony that an individual is assessed for services when they are put onto the wait list, and then once again when they are found eligible for, or not found eligible, but then start receiving waiver services. And the period of time between when they are put on the wait list and when they actually start receiving services could be several years. During that time, there's no reassessment. And so the committee indicated that it would like the agencies to work together to reassess those individuals to find out what those current needs are for individuals on the wait list, and at the same time sort of do that sort of reassessment for individuals receiving services so that the legislature can get a better scope of what those services are that individuals need. Sort of the next category of recommendations that I'd like to touch upon are just funding for the waiver. There was several recommendations for KDADs to review some of the rates for personal care attendants as well as supportive employment to see what those rates are, do an analysis to see how those rates might need to be increased, and to provide those recommendations again to this committee and its Senate counterpart. There was another recommendation for sort of that the legislature approve funding that would then go towards increasing the reimbursement rate that would then be an incentive for providers to increase direct support worker salaries to help retain more long-term employment, as well as the legislature identify areas in the budget where it can reduce expenditures in order to free up funding for the IDD waiver. And the last sort of group I'd like to touch upon is sort of the structure of the waiver. We heard a lot of testimony in the committee regarding sort of how other states have similar waivers and how they've organized that waiver. In Kansas, currently, the IDD waiver is a comprehensive waiver, which means that if you're eligible for the service or the waiver, you're eligible for all sort of 14 services that the waiver provides. And other states have different sort of waivers that are structured that allow for a little bit more kind of services tailored to the individual's needs. And the committee had recommended that the legislature sort of study and see what those other states did, how we might be able to restructure our waiver to sort of allow for that sort of more tailored approach. The last one on page 3 there was another one with regards to the legislature considering providing individuals who self-direct. So rather than go through an organization to get their sort of services, they choose them themselves. Provide them with individual budget authority. There was some testimony in the committee that would allow individuals who sort of take it on themselves to determine their services, to have a little bit more flexibility to meet their needs. And the final one is the last one on page 4 there, that the legislature explore potential legislation to provide sort of an automatic annual adjustment for reimbursement rates on the IDD waiver. And that was an item that was sort of flagged as should the LCC approve a special committee, that might be something that committee might be able to explore it as well. With that, the rest of the report just provides a brief overview of some of the testimony we heard, some of the presentations that were given, but I would stand for any questions.
Committee questions? Wow, you knocked me down, Matt. Good job. Thank you very much. And I might add, committee, there were many members from this committee on here, Representative Aziz, Ballard, myself, and Representative Lynn. So we had a lot of input. It was very informative. Representative Howerton.
Thank you, Mr. Chair. I just read that there's like a 10-year waiting list. Is it funding that is the problem, or is there another?
No, it's funding.
Funding, okay.
It would be about roughly $20 million a year, but it's not just that simple. It's a capacity issue. We're struggling with our ID and DD community now. It is very difficult right now to find. If I had one the other day at home in my county that a gentleman was taken into custody and he couldn't be placed, and so our local CDDO found a couch literally for him to sleep on, but it's supervised, so, but they did that, and they have the ability to do that, but just on exceptional situations like that right there, and then he was placed the next day by KDAD, so we don't have the capacity out there for anybody new, and that's what we have to build. It took me, I tell this story, I was much like what you just talked about. Well, if we had $20 million, we could start, and finally, folks were real nice to me for a while, and then finally they were like, well, you don't get it. We don't have the capacity. If you wanted to take those people off the wait list now, we still couldn't serve them because we don't have the capacity. So you have to build the capacity before you start to even address the wait list. And that's where we're at right now. And here's the next person will be some testimony on what we can do to kind of address that wait list. Representative Donahoe.
Thank you, Mr. Chairman. So what is being done on infrastructure? I know we've heard this every year. How has it increased? How much? Do we have any idea of what's been transpiring?
Are you talking about the wait list?
No, I'm talking about infrastructure. So, we can't handle people because we don't have the infrastructure.
Yeah.
But are we actually building any infrastructure at all?
We did not. We have not. As a matter of fact, we had testimony today in appropriations that we raised the provider rate increase last year by 7%. It was about $20 million, arguably $7 million. It's 60-40 split. And we put that into the system, and they're still struggling. COVID has, taken its toll on their workforce just like it has everything else. And basically that, I did not realize it at the time. We just got the figures back over through the summer, but there are roughly 20,000 employees that serve in the ID and DD provider waiver network. So spread that 20 million out over 20,000 employees, and then COVID hits, and they have competition with, as you said the other day, with fast foods restaurants and Walmart and all this stuff, and it didn't even make a dent in it. So we're back to the square when we were able to do nothing.
So for my first cynical comment of the session, I can understand why we haven't done anything with the $3 billion surplus. Amazing. Thank you, Mr. Chairman.
Yeah, and I think the only thing I'll say about that, and I certainly agree, but with that, we're trying to identify one-time money. And that is not a one-time money type of situation. If we were to give those increases, they would be ongoing annually. And so that's the difference on the money that we have in the surplus in the ARP bill. So I'm not happy either, but that's just reality. Any further questions? Okay, very good. Well, next we have up Amy Penrod, and she's going to talk to us about that waiver that we were talking about to try to get some flexibility in our ID and DD waiver to address the wait list. Amy, thank you for being here.
Good afternoon. My name is Amy Penrod. I'm the Commissioner of Long-Term Services and Supports with the Department for Aging and Disability Services. I have two separate kind of presentations for you today. One was a briefing on the 10% FMAP projects that the agency has planned. And then the second was on the IDD waiver and touching on that community supports waiver. I thought, if it's okay with you, Mr. Chair, I would start with the FMAP project and then roll on to the IDD waiver, because that will flow then onto some of your other conferees. Okay. So the FMAP project has the presentation, if you have a copy, has the state seal on the front. And I will just be covering the first few pages of this presentation. I realize it's a lot of information, and so I'd be happy to answer any questions you have either now or later after you've had a chance to look over the entire document. But in the interest of time, I'll just give you a quick high-level overview. So Kansas has a very unique opportunity based on enhanced federal funding for home and community-based services through a one-year 10% increase to the share of state Medicaid spending contributed by the federal government. This one-year increase in federal matching funds will result in new time-limited dollars that can be strategically invested in HCBS services in Kansas through March of 2024. Kansas is required to use the state funds equivalent to the amount of federal funds attributable to the increased FMAP to implement or supplement the implementation of, very wordy, but these are the rules, of one or more activities to enhance, expand, or strengthen home and community-based services under the Medicaid program. So it's very specific. We're drawing down this extra money, and the equivalent of that, those dollars have to be invested back into home and community-based services. Like the chair mentioned before, though, this is one-time funds. And so how do we invest in projects that are going to make an impact and set our state up for perhaps future investments and to provide us the information we need to make good, solid decisions about those future funding investments. So let's see. Slide number 2. KDADS did gather lots of ideas from several key stakeholders across Kansas. We talked with our advocacy groups, our service providers, other government agencies. My staff had a lot to say. They've got a lot of ideas too. And our educational institutions, such as the Lifespan Institute at the University of Kansas. And we started meeting and compiling and brainstorming a list of potential projects that would allow the state to strategically position itself and its programs for the future. We met with these groups between March and June of 2021, and our plan was due to CMS at the beginning of July. So we had a very quick turnaround from the announcement of this opportunity to then turn around and present a plan to the Centers for Medicare and Medicaid Services. Slide number 3, we did, since the potential number of projects far outsize the estimated funding available for investment, we did leverage some principles, guiding principles, to help us determine how we were going to use the funding. So we wanted to maximize the benefit to Kansas citizens, to invest in lasting impact and change, to ensure we had some flexibility to meet evolving needs, and to fully utilize all of this wonderful funding that we possibly could. So we did whittle down the long list of ideas was narrowed down into 3 priority investment areas based on the size of need that we were seeing and our alignment to the principles I just reviewed. Those 3 categories are workforce, employment, and access to care. So the workforce projects are aimed at improving direct service worker retention and recruitment, training, and hopefully leading and setting us up for some increased capacity and quality of care. Employment is the second category, and that will help us realize, the state realize its employment first requirements. So the state is an employment first state. We want to make sure that individuals that have disabilities that want to work have those opportunities to work. And that was one avenue that was addressed that we really needed to invest in. And then access to care, expanding some accessibility to HCBS through our transition management, helping individuals transition from institutional settings to home and community-based services, and then in building capacity. And so on slide number 5, this gives you a list or kind of a chart showing the final investment portfolio that we submitted as the state of Kansas and KDADS. This lists the 12 projects that KDADS has proposed to CMS for the use of this one-time funding. KDADS is estimated to draw an additional $80 million in federal funds. So we will be looking to reinvest that $80 million in the home and community-based services. And as you'll see, the workforce area of investment has by far the greatest amount. So of that $80 million, we're planning to invest 57.1 of that into workforce, approximately $2 million into employment, and then 20.7 million into access to care. I think our highest priority items on this list, the item number 1, the one-time retention bonus. That's not terribly descriptive in and of itself, but the goal there is to kind of stabilize and help sustain in the short term our home and community-based service, our direct service worker workforce by providing funding so that providers can do recruitment bonuses, retention bonuses, anything, in that line that will help them compete and retain employees. We know that we are asking our direct service workers to take on a lot of responsibility for the very low pay that is currently being offered. And it is difficult to compete with the service industries that are just down the street and offering $3, $4, or $5 more per hour. So that is one area where we are working very hard to get that rolled out as quickly as possible. So that's a really high priority area. We also want to allow for providers to design and submit applications for training grants. So we've heard a lot about not only are wages really important to workers, but also their training and feeling prepared for their positions and equipped to do their job. So offering training, helping individuals be invested in their careers as direct service workers and beyond as they move into healthcare. The other item I would point out, all of these are really important and I'm very excited about all of them, but the other one that I will point out is the study of the waiting lists. And you all have touched a little bit on that already. What we would like to do is be able to go out and reconnect with all those individuals on the waiting list, make sure we understand what their needs are. As Matt said, we do an assessment at the time they are placed and found eligible for the waiver and placed on the waiting list. But unfortunately, we do have a several-year, almost a 10-year waiting list. And so needs can change significantly between the time they're placed on the waiting list and when they maybe become eligible to be offered a spot. So part of our planning then is to reassess, focus on what the needs of those individuals are, and then really be able to use that data to kind of predict where we need to go with our services, where we need to build our capacity, how we need to invest as we move forward. And that'll not only help the state as it makes funding decisions about where to invest, but will also help our stakeholders, our providers, know where the needs are so that as we provide funding for them to build capacity, they'll be more prepared to build that capacity with us. So I will go ahead and kind of stop there. I have provided a page on each one of these projects, kind of how we arrived at the need and some of the statistics that reflect the need. And I will stand for any questions on this particular.
Committee questions. Representative Ruiz.
Thank you, Amy, for the information. This is really good. I have some questions on the workforce.
Yep.
The folks, the workers, is it the direct service workers that are going to get this bonus, one-time bonus, or?
Yes, the intention would be that those hands-on individuals that are doing the ADLs, the IADLs that are really working with individuals would be the set, that's really eligible for these bonuses. We are not talking about management. We're not talking about licensed professional staff. We're talking about really that hands-on day-to-day worker.
How is that getting how is that money going to get to the worker?
So that's
Who's in the middle?
Yeah, that's a really good question because we had a lot of great ideas, as you can see, but then you have to kind of put pen to paper and figure out how you're going to go from where you are to where you need to be. So we have identified that we do need some assistance in collecting some data from our providers, the providers that are interested in participating. We will be selecting likely a vendor for that. I'm close on that. And then the vendor will help us decide who gets what and how much and kind of keep track of all that record for us because we do have a lot of reporting requirements that come with this money. So we want to be sure we cover that base too while we're doing. Then we had an additional challenge in that having that payer relationship with providers. So the money would actually need to flow to the agency or to the provider who would then have to make that bonus payment. And in the case of a self-directed individual, someone who hires their own employees, they utilize a financial management service provider. And the thought is that that entity would receive the initial payment and then help disperse as the self-directed individual sees fit.
More questions. You said something like providers who are interested in participating.
Mm-hmm.
So what does that mean?
So we will need to collect some information. We'll have to know how many employees specifically are out there by provider. We have to know how many vacancies they have if we're going to offer funding for recruitment bonuses. So we've got to have some information collection there. I would hope and I expect to have a very robust response to this opportunity. But the fact of the matter is I can't make someone, a provider, participate if for whatever reason, they elected not to.
And is there something built in that would, that if a provider is participating, that the worker is guaranteed to receive that? Because we hear that they didn't receive anything before. So I'm, just really concerned that to make sure that the worker really is going to receive the bonus.
That is something we want to make sure happens as well. So through the reporting and potentially some attestation, I'm not sure what that might look like at this moment, but that is a consideration that we are solving for. We want to make sure that this money gets to our direct service worker.
Thank you. Thank you, Amy. Thank you, Mr. Chair.
Representative Helmer.
Thank you. So I'm understanding that you don't have any stipulations drawn up yet for the goals for what these providers are looking like.
I do have some drafts. I have been working with our stakeholders, some of our providers, just want to make sure that we are, in addition to kind of making sure the money gets where we want it to go, but we also want providers and the self-directed individuals to have the flexibility to to direct that funding to the workers in a way that is beneficial for that area. For example, if a local employer is offering a $2,000 recruitment bonus and they need that to be able to compete, that may be kind of what they want to do on that recruitment side. How exactly they disperse that money, whether it's in one chunk or whether it is in several broken out chunks. I think that's the type of discussion that we've been having is what level of flexibility do providers need in order to recruit and retain in their area, because what works in eastern Kansas may look a little bit different about what might work in western Kansas. So we want to strike a balance.
Thank you. I am getting overexcited about this. I just see so much potential in this. And thank you. What a wonderful presentation you brought to us. Thank you very much. Thank you, Mr. Chairman.
Committee, further questions? Representative Ballard.
Thank you. All right. I would like to follow. If I look at one-time retention bonus, okay, now, at one point you mentioned recruitment. Okay, but this says one-time retention bonus. All right, so maybe I wasn't listening carefully enough, but how are you going, if we, retention, how are you choosing the people that you're going to retain? Is that everybody? Or will it be what level? Is it aimed at entry level?
It is aimed at that really direct hands-on worker. So I'm in my mind, I'm thinking the $15 an hour or less worker. Those are the ones, we need to be bringing in the door. They're the ones assisting with those daily activities that help with the quality of life for our individuals on the HCBS waiver. So the goal would be to provide funding so that a provider could give a retention bonus to each of their direct service worker employees, or a recruitment bonus to those that are coming in the door.
Now, will the recruitment bonus be the same as the retention bonus? And I have a reason for asking that question, because people that have been working for a while, they get X amount, and if the new people get the same amount, I was here first. What do I get?
Right, and I understand that, and so that is another thing I'm kind of trying to wrestle with and solve for as I'm talking with providers about what would work for them. My initial kind of draft guidelines did have a differential between the recruitment bonus and the retention bonus. So I'm still a little bit in flux there, but what I'm trying to do is run several things concurrently. I'm trying to get a vendor on board so that we can begin that process of collecting the data we need, while at the same time getting some guidelines going and bring this all together, kind of building the plane while I'm flying it here.
I love it, I love it. But now I want to move over here. Is this retention bonus for you to stay an additional 12 months, additional 18 months? If you're the new recruit, will you stay for 12 months or whatever? Because what do we know? After 90-day training and everything else, they will move and go someplace else.
I'm hopeful that we can include some parameters around, perhaps you don't get the entire bonus all right up front, that some of it comes a little later down the road.
Basketball coaches, you get this much, you get to keep this much, you get to move,
Right. Where things do get a little difficult is we do want to offer providers as much flexibility as possible. I mean, they know their areas, they know their employees, they know what their competition is like. So that flexibility is pretty important. At the same time, I also can't make this program so complicated that nobody can participate. For example, I've got to keep the reporting as simple as possible. There's a lot of recruitment or retention bonuses that you pay the bonus, and if you leave prior to a certain period of time, you have to pay back. Well, I don't see our providers having the bandwidth to be chasing down former employees to recover funds. So I think we're going to have to strike, a balance there. And so I'm hopeful that by working with them a little bit more, I can pin that down.
Thank you, Mr. Chairman.
Committee, further questions? Well, Representative Howerton.
Sorry, thank you, Mr. Chairman. This is new to me, and these numbers are kind of daunting, to be quite honest. But can you explain to me, there's several studies on here, and they're at $1 million? What goes into that?
For example, the waiting list study, honestly, that's one I'm super excited about, so I'll talk about that one. What we need to do is to actually reach back out and make contact with the 4,500 plus people that are on our waiting list. They're spread out all over the state. That takes time and resources. Currently, we pay I believe it's $150 per assessment for that initial assessment, and then each annual assessment when an individual's on the waiver. So trying to know that I will at least have to pay somebody that much to go out and kind of do that work. In addition, we're also expecting the data to be compiled into some usable information that can be predictive. I'd like for the data to kind of tell us under what circumstances an individual is likely to face a crisis where they need crisis access to the waiver. If we can predict that, then perhaps we can get to them sooner before it's a crisis. The crisis is not a great way to enter the system. It's not good for the individual. It's not good for our providers. They're not as prepared as they could be. So it adds up by the time you are looking at actually going out and really touching all these folks and compiling the data and providing that feedback and giving us a system to predict needs into the future.
Is it subcontracted out?
It will be. I will be issuing a request for proposal, so it will be bid, and yeah.
Committee, further questions? Well, Representative Ballard stole a little of my thunder on that. I think, just with human nature, you give them $2,000 up front, they're gone, So I would certainly recommend some kind of way to guarantee or, And the other thing I was going to ask is, so this covers all 7 waivers, HCBS waivers?
The recruitment bonus retention, yes, it would be across any of the way.
CBS, all 7. So, and roughly I saw in here about 24,000 people is what you're.
That's what we estimated, and depending on our uptake rate, we may be able to provide a little bit more or a little bit less, but we had budgeted for approximately $2,000 per worker.
Okay. And then to respond to Representative Howerton's questions, Amy's been grilled on that $1 million price tag quite a bit in the past. So we about had a corner when we saw that. But so she has her spiel down pretty good. Representative Reeves.
Thank you, Mr. Chair. Amy, under the employment first section, by the way, I need to say again how awesome this is. It's so easy to follow it and understand it. On the investment opportunities, a hire contractors study how to make employment first a reality, looking at supported and integrated employment. Will the contractor that is hired for this, will they also look at who is employed under sheltered workshops?
That would be a part of the entire kind of the scope. What we're looking for is to ensure that we're providing the appropriate services. Right now, our supported employment rates and the rate methodology is such that we really don't have a lot of providers able to kind of embrace it and run with it and provide supported employment. So the goal would be to increase the numbers on supported employment. And we have received a lot of really interesting information. about how some other states are doing their methodology even. Of course, the rate is important, but how you pay that rate and ensuring that you are incentivizing increasing independence for an individual, but still providing support as needed, as opposed to perhaps kind of a perverse incentive to continue to provide intense support to an individual for a very long time, even if they don't really need it because of the rate. I don't suspect that, but there's some really innovative things that we can do. We just need to figure out what will work well for Kansas. We have, we've got a unique system, so we need to make sure that and that we can dovetail in with vocational rehab and, that the whole entire system is really working together.
They'll also be able to tell us what the salary range is of everyone right now.
I think so, yes. We kind of need to know, we know what rate we're paying now, but that doesn't necessarily translate into what rate a supported employment kind of worker that's actually going out is paid.
Okay. No, I was thinking about just the worker themselves. Yeah. The range of salaries that not the. I'm talking about the person receiving the services and they're working.
I gotcha.
Yeah. Okay.
Yes.
Salary range. Yeah. Thank you. Thank you, Mr. Chair.
Very good. Committee, further questions? Okay, very good. Thank you, Amy. On to the next one.
On to the next. Okay. This one is titled Briefing on IDD Waiver and Community Support Waiver. So I will start on slide 1. So just, and this may be basic for some of you that have probably heard this before, but I will run through it pretty steadily, but if you have questions, please let me know. Starting out with what is an HCBS waiver. So a 1915C waiver, which is what Kansas has, and the IDD waiver is one of them, enables states to tailor services to meet the needs of a particular target group. Within these target groups, states are permitted to establish additional criteria to further target the population to be served on a particular waiver. For example, a population can be targeted by age or diagnosis, such as autism, brain injury, or intellectual and developmental disability. In general, to operate a home and community-based service waiver, a program, it is essentially an alternative to institutional placement. So for the IDD waiver, the institutional equivalent would be an intermediate care facility for individuals with intellectual and developmental disabilities. The state operates 2 ICF, that's the acronym, ICFs, that's K&I and Parsons. There are also a few, but dwindling, number of private ICF institutions that are available. So the state has to demonstrate that providing the services on this waiver program won't cost more than providing the services in an institution. We also have to guarantee and protect a person's health and welfare, and then provide adequate provider standards and ensure that the services follow an individualized and person-centered plan of care. Kansas operates 7 home and community-based service waivers, one of which is the intellectual and developmental disability waiver, and you'll hear it called the IDD waiver. The IDD waiver delivers community-based services to individuals age 5 and older who have an intellectual and/or a developmental disability. Services are designed to help individuals remain in the community and maintain their physical and mental health. The services offered on the IDD waiver allow participants to live as independently as possible in single residence or group home settings. And I have listed the 14 services that are available to individuals on the IDD waiver. The final service listed, targeted case management, is technically a state plan service, but for all intents and purposes, it is a Medicaid service that is offered to this population. On slide 5, I've talked a little bit about the eligibility process. So the first step in a person to become eligible for this waiver is to look at their functional eligibility. So it looks at an individual's need and their diagnosis to see if they meet the criteria that have been established for the waiver. For the IDD waiver, our Community Developmental Disability Organizations, or CDDOs, conduct those assessments. The next step, once an individual is found functionally eligible, is to look at financial eligibility. And the financial eligibility for an individual applying for waiver services looks at the individual's income, as opposed to the regular Medicaid looks at the entire family's income to determine whether they qualify or not. For a waiver, that individual's income is the only income that counts. And then finally, once that threshold has been crossed, the financial eligibility, then an individual can select their MCO and begin to work with the MCO to develop the plan of care. Individuals enrolled on an HCBS waiver are reassessed annually or at any change in condition to ensure continued eligibility. So for the IDD waiver, there is the single point of entry for the single point of entry for Kansas. The Community Developmental Disability Organizations, or CDDOs, evaluate that functional eligibility and the programmatic eligibility. They work with a participant and their family to access services from a variety of community service providers in their area. And then I have included on this slide the criteria for eligibility for the IDD waiver. On the next slide, I have listed some of the roles and responsibilities of community developmental disability organizations. These are required by the Kansas Developmental Disabilities Reform Act. So a CDDO provides a single point of entry for services. They provide information and referral services. They coordinate access to services and supports. They do maintain a network of affiliate providers. They do assist with capacity planning and really maintaining contact with the individuals that are on the HCBS waiting list. On the next slide, I included a map that shows the kind of the catchment areas of the 27 existing CDDOs. On slide 9, sorry, am I okay? Okay. On slide 9, I have given some information about the IDD waiver enrollment and waiting list, and I do sincerely apologize. I did not update this slide, so the numbers you have before you are from August of 2021. I can do a little bit better than that on the numbers. So as of November of 2021, we currently have 9,083 individuals enrolled and eligible for waiver services. For the waiting list, as of November 2021, we have 4,622 individuals on that waiting list. It doesn't take long for it to creep up. And this information is still accurate. The 9.5 years is the length of time on the waiting list. And that's based on the individual that's been on the waiting list the longest was added on April 11th of 2012. So they have been waiting since that time for services. Were found eligible and have been waiting since then. It is important to note that approximately 70% of the individuals on our waiting list do have access to the Medicaid state plan services through CanCare. So while they're not able to receive the menu of waiver services, they can get their physician appointments, their regular medical covered. And that would be, based on other eligibility criteria, perhaps financial eligibility, et cetera. But approximately 70% do have that medical coverage. I've also provided slide 10 some demographics of the waiver and waitlist population. You'll see that the participants on the IDD waiver are, young adult to older adult, and a lot of the individuals on the waiting list are that younger population. So individuals can be added to the waiting list at age 5, and we do see that, particularly with a waiting list as long as we have. If an individual is eligible, we'll go ahead and get them on that waiting list. So I wanted to touch a little bit, and I've already talked a little bit about the waitlist study, but on slide 11, this goes into a little bit more detail about the study itself. So as I've said, there's 4,600 Kansans on the waiting list for intellectual and developmental disability waiver program here in Kansas. Unfortunately, we don't know as much as we could about those individuals. We can track some basic information, their age, residence, what their needs were at the time they were assessed and placed on the waiver. But there really isn't a process established to gather information about their current needs or their anticipated needs during the next 5 years. We've also identified that a significant number of individuals are moving off of the waiting list and onto the waiver due to a crisis. And as I had mentioned before, that's not a great way to get into services. It's about the only way now with such a long wait, but we would like to prepare and be more proactive and allow providers to have some preparation for the capacity needs in the state. So we do need a system for monitoring the needs of people on the waiting list. It is critical, I think, for the state to effectively serve and then plan for the services for individuals with intellectual and developmental disabilities. So the overall goal of the project is to gather information to inform some data-driven decision-making in planning. We want better outcomes for individuals with intellectual and developmental disabilities in their communities. This project will support capacity building and in particular further implementation of the Employment First Law, which we've also identified as a need, since it would inform us as the state, the number of individuals with an intellectual and developmental disability who are ready to work and could work with appropriate supports in place. So, that's actually another avenue, maybe a little bit untapped for some additional workforce. We've got a lot of folks that are very capable of a lot of things with a little bit of support. So identifying that is going to be really important. And then really on slide 13, I've identified some of the benefits of the waitlist study. Really the key ones for me are the ability to document the needs of people coming off of the waiting list, to identify and prevent crisis situations, to predict service needs at the system level and the CDDO level, currently and up to 5 years out, so that we can plan for appropriate services over time. And then really the ability to make some data-informed decisions about system funding needs. I think that's really very important. We need to know where to invest the money, how much to invest, and what outcomes can be expected then from that investment. Okay, so my last little bit here is more about addressing the waiting list. One option that has been suggested is to create a second waiver, a second IDD-focused waiver to serve individuals with intellectual and developmental disabilities. And the type of waiver that was suggested was a community support waiver. Many states operate multiple waivers for a particular population, offering a different menu of services tailored to the needs of the population that they're kind of going for there. So a community support waiver provides a limited set of supports for those that have a place to live in the community and receive substantial support from family or friends. So this could be youth or adults. The services offered could be tailored to meet those needs of individuals that have that place to live and some natural supports. Residential services typically then are not included as part of a community support waiver. Because it would have a limited menu of services, a community support waiver would likely cost less per person to operate. Although I will say that the total cost would be highly dependent on the specific services offered and any additional criteria that might impact utilization. Currently, residential services account for approximately 55% of the cost of the IDD waiver for an individual. So conceivably, again, it would depend on what services we included in a new waiver that would drive the cost. But if you were to take our existing comprehensive waiver and subtract residential services, you'd be looking at at least a 50% reduction in cost. Now, I do want to be very clear that this suggestion regarding a community support waiver is in addition to our existing comprehensive waiver, not as a replacement for. We have a lot of individuals that need that residential support, and I don't think you would find stakeholder support for making that kind of change. I just want to be very clear, this would be an additional waiver. However, with that lower cost per person, you could probably make a decent dent in the waiting list by serving those youth that are in a family home currently, and that just need a lesser number of supports or would have less utilization. I did want to also mention, as we explore some potential options for addressing the waiting list, I do want to note some points of consideration when it comes to the development and implementation of a second IDD waiver. So the development of a new waiver will require some significant state staff resource time for development, as well as a lot of stakeholder engagement. We will need to bring lots of folks to the table and talk about what's going to be most beneficial for these populations. The results of our waitlist study could be very telling and very informative as we're bringing information to the table about the needs of individuals on the waiting list. My team, if we are to operate another waiver, we would need additional program staff to support both the development and the operation of an additional waiver. I also just want to level set, just make it very clear that the creation of a new waiver cannot happen overnight. In addition to that time that it takes to bring folks to the table and decide what we want this waiver to look like, if this is the path forward, we have to be realistic in our estimates, our timelines for development and implementation. There is, in addition to the development process on the state end, there is a significant administrative process through the Centers for Medicare and Medicaid Services to get that waiver approved. And then finally, and probably the most important point to mention in all of this, is that creation of a new waiver does not solve the current issues around provider capacity to serve individuals. So I point out that the provider network for a new waiver serving individuals with IDD is likely very much the same provider network that is serving the individuals we have now on the comprehensive waiver. Additional action will have to be taken to bolster the provider network and the capacity of our current system. Creation of a new waiver is not automatically going to expand our provider network. So we really would have to tackle this from different directions in order to see some success. Because like I've said before, you could write me a check, for $200 million, and I could take all these individuals and say, poof, there's no waiting list. But the reality is there are not providers out there that have the capacity to serve them. So it is about funding for those waitlist participants, but it's not only about their funding. It's also about figuring out a way to build the capacity. And I will stop there and I'll stand for any questions.
Amy, thank you very much for that, but the bottom line is this didn't happen overnight either, and I'm certainly, and I know this committee, we're certainly not interested in wasting any more time than we have to. I know it's a big lift. The committee knows it's a big lift, and thank you for telling us that. But nevertheless, it's something that we have to do as a state. And I might add there are other waivers out there. The community support waiver is just one. But there are a lot of states that we can use as examples that have done a very good job with their wait list and with their ID community. So we don't have to reinvent the wheel.
Right.
But we've got to get the conversation going, started, and, build. So anyway, that's my soapbox for the day. Committee questions? Representative Elmer.
I have a comment. And I have a comment. As a counselor working with mental health, I am just appalled and very saddened that we haven't done anything quicker. So I'm cheering on getting something done, and I like this example given. We had children that would be in crisis, and we would be calling around, and as you know, probably 3-4 years ago, Kansas City was the only place you could take somebody with severe crisis, and there was nowhere to go. And these children were really, really in crisis. And something like this, I'm just thinking, why can't we get this going? I'm all for it. Thank you so much, and thank you for your work. Thank you, Mr. Chairman.
Representative Vaughn.
Thank you, Mr. Chair, and thank you for your presentation. I am really excited about the idea of the community support waiver, and I was interested to know if something like this is implemented. I know it's a multifaceted issue with the provider network, but hypothetically, how could this reduce the wait list for the comprehensive IDD waiver in terms of the amount of years that an individual's on that waiver?
So hypothetically or conceivably, there would be some individuals that may be on our comprehensive waiver currently that don't need that full level of service, and maybe all of their needs could be met on a light waiver, or this community support waiver. If we were to do that, you may free up some space then that folks on the waiting list that need that level of support could transition then onto that waiver. You may also find that based on just purely on demographics, with the number of youth and very young adults on that waiting list, they may very well be living with family, or we would expect that they would likely be living with family, and they could likely have their needs met then with the community support waiver, which does have very likely a lower price tag. So if you are going to invest additional funds, you could probably serve twice as many people with the same amount of money by pulling out that residential services. service. And then again, just kind of depends on how you slice and dice the services. But that would be, if you didn't have the provider network issue, that's how I would see this improving the waiting list.
Thank you. And I have one follow-up, if I may. So looking at the special committee's report, this is one of the things they kind of talk about, how there are the different waiver authorities, if I'm making that connection correctly. And I was just wondering, are there other ways or additional IDD waivers that could also be created to help with this issue as well, to further siphon out people based on the services they need versus putting them in one comprehensive list? Or are there studies that could be done with some of the FMAP funds to kind of to look into some of that? Thank you.
Yeah, I think that there are a lot of different options, ways you could kind of parcel out the different populations and, kind of target services for those individuals. There are, a lot of states have more than one IDD waiver. Some have 3, 4, 5. Of course, the more waivers you have, the more administrative stuff that comes along with it. But they are able then to tailor that package of services and benefits more towards a particular population. So, there are some benefits. I think we're seeing with this one, if the state of Kansas is going to take a step in that direction, a community support waiver may be a very good way to go in making that progress.
Great. Thank you. Thank you, Mr. Chair.
Ultimately, we do not know. I mean, when the study comes back and we see what we need, and the deep dive, we'll understand a whole lot more. Representative Ruiz.
Thank you, Mr. Chair. I was looking at the role of the CDDOs, and I guess I've never really educated myself enough about the CDDOs. Do they provide services or they provide resources?
The role of the CDDO itself is to, provide kind of access to coordinate, to kind of provide that information and referral type process. We do have, our CDDOs do receive a little bit of money for state aid, and they can invest that then in some services, or kind of to get people over a hump, I guess, if they have a crisis situation. That money, I think, if you asked a CDDO, they'd say it doesn't go very far. We do have some CDDOs that are linked with community service providers. So some of them have both perspectives, but the actual role of the CDDO is not to provide those direct care services. It's to be that, kind of that gatekeeping, that administrative function.
So they do maintain contact with the individuals on the waiting list?
Yeah, we do ask, we do try to do it twice a year. It is part of our contract with the CDDOs that we make sure that we have updated contact information, that we haven't lost track of anybody, and that we keep that wait list clean. And we do that at 6-month intervals.
That's how we know how many people are on it now, right?
That, and we've got an actual list of 4,600 people that we're tracking, and each CDDO tracks the folks that are in their area.
I think that's it. Thank you, Mr. Chair.
Representative Clifford.
Thank you, Mr. Chairman. Thank you for your presentation, Amy. I'm a former county commissioner in Finney County, Kansas. I know Mark Hine very well, SDSI. We would have to be cautious with the county commissions. Mark comes in every year for some funding. So when the one-time money arrives, commissioners will become aware of that and then maybe cut back on their contribution. I realize it's a pass-through when it's going to the employers, so there's always unintended consequences. So I'd want that rollout to be cautious so they could not suffer a haircut from their county commissions who will see that money flowing in. The other thing is that I'm an eye surgeon and I have a lot of patients who are Down syndrome, who have a Down syndrome, and many of them do have that family support or live very independently on resources through the family. So I really like the idea of the community support waiver. I think that's an excellent idea. Thank you.
Representative Ruiz for the 10th time. No.
Thank you for indulging me, Mr. Chair. I knew I had another question. I was like, where did it go? So who makes the decision whether we want to start another waiver? Like the community support services waiver?
If the initiative could come from any number of places. I mean, I can write a waiver application, but I have to have financial support to operate it, and to, we'd have to establish rates, et cetera, for that waiver, all that whole process. Ultimately, the legislature has to support it by funding it. So, I mean, the kind of the last, the bottom line is we would need your support.
So this committee could make that recommendation? Mm-hmm. Okay. And it would not require a specific bill. It could come just as a recommendation out of this committee.
In the past, I'm thinking of the expansion of the brain injury waiver, the populations that we were serving on the brain injury waiver. When we expanded that from a traumatic brain injury waiver to include acquired brain injury in youth, that was done via a proviso in the appropriations bill.
Thank you. Thank you, Mr.
Very good, Amy. Thank you very much. Committee, further questions? Okay. We've got two more people here to testify, so we'll make it quick. Representative Ballard.
You know what, it's not, I think she answered part of it because I was trying to figure out exactly how we go about doing the waiver. But how can we do that waiver in such a way that it doesn't look like, you called it community waiver light, all right? A lot of people see light as less than the other waiver that funds everything that takes you, 9 to 10 years to do. So when we do that, do we do it in terms of, this is, how can I say this? For maybe those that don't need all 6 or all 7 things, but they only need like 3 or something like that. This fits their needs right now. But it's not less than, it just says that they're not as severe or they don't need as much. Do you understand what I'm asking? Because otherwise people would say, well, I don't want that waiver, I want the good waiver. Right. Okay.
Yeah, I would anticipate working with our stakeholders to figure out exactly what that, what that new waiver would look like. And we would have a lot of work to do regarding eligibility. How do we decide what factors go into which waiver are folks eligible for, et cetera. And we certainly would not want anyone to feel like, they should have the comprehensive waiver if they don't need that level of support. I think that likely there would be some opportunity for transitioning. So if you have a youth or young adult that has the family support and they're doing fine, they could be on that community support waiver for quite a while, maybe for the duration, but if there would come a point where they needed a more intensive support, then I guess I would anticipate there'd be opportunity to build in some ability to transition.
Thank you. I'm with the chairman on this. We have to start somewhere. Okay, thank you.
Very good, Amy. Thank you very much. Next, I have Nick Wood. Nick, you have about 30 seconds now. We've burned up all your time, so I hope you can talk fast. Thank you, Nick, for being here.
I will certainly, and I will be able to talk fast because Matt and Commissioner Penrod did an excellent job and covered actually quite a bit of what I would say. So, but thank you for having me here, Chair and members of the committee. I'll just say we've done a lot of looking at these community support waivers across the country. Interhab was interested in a community support waiver concept back in the mid-2000s when they first kind of became available under CMS or under Medicaid. Commissioner Penrod and Matt are correct. They're typically kind of limited to people who want to live in their own home or their family home versus a residential group home 24/7 care setting. And that's what makes the cost less. It's not so much that you would cap the costs, it's that they don't need as much cost because they're more focused on independent living and employment. So please take a look at my testimony. There's some details in there that I hope you'll catch. These waivers are typically operated side by side with more comprehensive waivers. Every state in the country has a comprehensive waiver, and you know that makes sense because they're considered a waiver against an institutional level of care. So all these folks have been determined to need an institutional level of care, so 24/7 care. So when states first started to develop these comprehensive waivers, that's what they were thinking. And then subsequently they said, well, maybe we can develop community support waivers that are just for people who don't want or don't need 24/7 care. So a lot of these waivers rely on individualized budgeting, and I would encourage the committee to continue to explore that. It's very popular with families, and I would also suggest that it's an efficient way to deliver and get organized services. I've got sort of a description of individualized budgeting on the back half, or on the back side of my testimony. Those are CMS's rules. And if you look at them sort of through the eyes of a parent, and you have a child, adult, or a son or daughter who's a child or adult, and you're thinking about their 7-day week, how would you sort of pick out the services you need, thinking about what their needs are through that 7-day week? So Commissioner Penrod said there's a lot of states that have these. CMS has approved an awful lot of them. There's 35 states who have community support waivers. By my count, going through all of them, there's 43 community support waivers, so there's some states that have more than one, including Missouri. All of these states, right, and I think I've said this before, I still haven't found another state that only has one waiver like Kansas does. So even if they don't have a community support waiver, the chances are they have some other type of waiver for this population. I want to say something about estimated service costs. So went ahead and threw my hat in the ring to do that. But it's by looking at how other states have operated similar waivers, trying to find waivers in states that are comparable to Kansas, so it's more of an apples to apples. I've checked with a number of expert sources and think that it's more than ballpark. So kids are typically less costly to serve. And we're guessing that that's going to be about $11,000 per participant. Again, this is on the backside of my testimony. For adults who would be served on a community support waiver, so 21 and over, we think that would be about $19,000 per participant. Those percentages, 58% being kids, we took that from Interhab's survey, where we got about 40%, we think we got about 40% of the existing waiting list. So we think about 58% of them are kids currently waiting, and would be covered on if we were to adopt a children's IDD waiver, for example, which has been a discussion in the autism task team, which has been kind of ongoing discussions about waivers for kids. Um, I think that pretty well explains it and sums it up. We would just encourage, to move with haste, I guess. I hear Commissioner Penrod saying, it takes a lot of resources and it's a process, quite a process. I personally participated in the adoption or implementation of a couple waivers, and it is quite a process. You have to write the waiver language for one thing, and it's a long application, and there's a lot of back and forth with CMS. But we would think that CMS, or I would think CMS, will be ready to provide technical assistance to Kansas to do this. There's always a stakeholder engagement period that you have to go through, and then there's public comment, so that takes some time, and then you have to get approval from CMS. But these are not the most complicated waivers that exist that we could apply for. And like I said, I think there's a lot of technical assistance out there. So understanding it would take resources for KDADs. I can't just snap my fingers and dedicate their human resources to something like this, but have faith in them and in the rest of the IDD community that we can all work together to get it done.
Very good. Committee questions. Representative Clifford.
Mr. Chairman, I'm new, Dr. Clifford from Western Kansas. I just wondered who you are and who you represent.
Sorry, I skipped that. I'm Nick Wood. I'm the Associate Director at Interhab. We're one of the IDD provider associations in Kansas. We have 44 members across the state. In your area, it would be Arrowhead West is one of our members. I've worked in human service programs for the last 20 years or so, including a stint with the state of Kansas. I was a disability rights advocate for a while, and I've been with Interhab for about 3 years.
Thank you. Thanks, Mr. Chairman.
Committee, further questions? Well, I can say Nick is a good resource, and I call him when I have questions from boots on the ground folks as well as other folks. But anyway, and feel free to call him, especially at midnight or anything like that.
Please do.
So
I'm waiting.
I do call him in on some odd hours. But anyway, thank you, Nick, very much for being here today. Next, I have Tammy Allen. Oh, is she back?
Hi, I am Tammy Allen.
Oh, there she is. It says that even. Thank you very much for being here. Sorry we took so long, but if you'll introduce yourself for us and continue on.
Chairman Carpenter and the members of the House Committee on Social Service Budget. I really appreciate you giving me the opportunity to give my testimony today. I will try to make it quick. It's been a very interesting conversation. I am the co-executive director for Families Together. We serve families that have children with disabilities and special health care needs. We are the state parent training and information center. I am currently located in Wichita, but I am a native of Western Kansas. We work a lot within the education system, but I think more importantly, I am actually coming to you as a parent of a young man who has special needs. You do have a copy of my testimony. I'm just going to highlight it really quickly. He is currently on the waiver and is receiving waiver services. At this point, because of the waiver, he is truly experiencing his good life, living independently on his own. He's employed, integrated employment, and very involved in the community. But it hasn't always been easy for him because when we were trying to plan that transition piece from high school, we did not have the waiver option. So really trying to plan for his future was very difficult because basically it wasn't a matter of moving out and living independently on your own as he had wished. We had to kind of change that a little bit because of the lack of supports. However, he does currently have those supports and is really living a good life. But as we experience this and we work with families in the education system, transitioning to adult life, a lot of our kids, because of the lack of that waiver support that they really need, are graduating literally to a black hole. They're graduating to living at home and really relying on family to be able to help them. And so they're really not getting that productive life that they were really hoping for when they transitioned. And families are really desperate in being able to support them. And because of this, and we really need to look at the fact that some families have more than one child with special needs. We have several families that have maybe 2 children with autism. And so, or they may have multiple needs. So families are really struggling to really take care of their children. We are seeing a lot more families quitting their jobs because there is no waiver support. So they are actually quitting their jobs and to have to stay home to take care of their children. They may send them to school, but they're consistently being sent home. And families really aren't knowing what to do. And this really affects that whole family unit. We are also seeing many parents that are aging. They've been taking care of their children with special needs for a long time, and they're starting to age. They're really struggling to figure out what is going to happen to my child because there are no supports for them, and they're wanting to plan for that end of life. And so they're really kind of struggling with that as well. So I think the main thing is for my son, it is important for him to be a part of the community, to give back to the community. It's important to him to be able to vote and get out and do those things that his peers are able to do. And with the waiver, he is able to do that. But there are still so many families during this time having to wait that 9.5 years to be able to foresee their child's future. And so I'm going to speak for Nick and say we really need to move with haste because our children's lives and our futures are really at stake. And we want to be able to give them that opportunity to be a voice and for parents to be able to see their kids be successful and feel comfortable in the community. Thank you guys for listening.
Very good, Tammy. Thank you very much for that heartfelt testimony, and I think I can speak for this committee that we all understand. Maybe not to the depth that you've lived it, but we do understand the issues. Committee questions? Well, thank you again for being here, and we appreciate your time.
Thank you.
Okay, very good. Committee? Oh, yeah. Oh, I thought it was written only. No, I'm sorry. Aldona, is that it? Aldona Carney, are you there?
I am here. Can you hear me?
Good. Thank you for hanging, and thank you, Francie, for reminding me. I saw the written only at the bottom. Okay.
Can you hear me, Chairman?
Yes, we can.
Okay. Chair Representative Will Carpenter, Vice Chair Representative Megan Lynn, and all the members of the House Social Service Budget Committee, I want to thank you for this opportunity to provide testimonial to the importance of funding the wait list and providing the community support services. My name is Aldana Carney, and I, along with my husband, Pat, are the parent guardians to our son, Neil, who is a 27-year-old young man with severe autism. Ask any parent of a child with special needs what is one of their biggest fears, and they will tell you about their concerns for their child when they are gone. Not long ago, I was at a meeting about how to acquire state benefits for our loved ones with intellectual and developmental disabilities, IDD. I had a conversation with 2 of the mothers sitting next to us that had just started the daunting process for their adult sons with autism. Both of their sons were aging out of the school system. They felt dejected and totally discouraged to learn there was an 8 to 10 year or longer wait for services. Sadly, this happens more often than not. When I inform a parent or anyone about the wait list and how long the wait is for services, they are shocked. And they can't believe that the wait for services is so long for some of the most vulnerable citizens in our state. Our son Neil and many others will need the same level of supports and services for their entire life. There is no cure for autism. They will not grow out of their disability or be magically cured because they aged out of the school system. I remember vividly how important it was for me to have respite care as Neil was growing up. Neil's the youngest of our 5 children, and I literally could not go to the bathroom or cook dinner. unless somebody was watching him. Thankfully, we had a case manager who helped us navigate the very confusing and endless paperwork required to receive services. So many with IDD fall through the cracks and don't receive proper services because their parents don't know where to start. Case managers link IDD individuals with the community resources available to meet their needs. And providing community support services could help overwhelmed parents to be put in contact with others to provide the vital services needed for their son or daughter. I would be remiss if I didn't mention the capacity crisis and the importance of building capacity by making sure the direct support professionals, DSPs, are paid a living wage. We are extremely grateful for the services that Neil receives, but we have been waiting for a different residential setting for almost 2 years now. Neil is a dual diagnosis. And what that means is Neil has a physical disability, which is autism, and he also has a mental disability, which is OCD, ADHD, and pica. Neil requires 24/7 round-the-clock care. Since Neil has behaviors and more specialized needs, it makes it even more challenging to provide those services to him in a residential setting. The capacity crisis and the need for alternatives until the crisis can be fully addressed is critical to the health and safety of our loved ones with IDD. And lastly, I'm just going to add one note that I think is really important for the committee to understand. When Neil was diagnosed, over 20 years ago, the occurrence was 1 in 500. Today, the occurrence for diagnosis of autism is 1 in 44. So this is not going to go away. We have more and more children entering the school system with autism at different levels of autism and also entering into adult services. It's going to continue to grow. So something, and I totally agree with everybody when there's such an important need to do this as soon as possible. I just wanted to thank you guys so much for listening and being a voice for the voiceless. Thank you very much, and I'm happy to take questions.
Committee questions? Seeing none, thank you very much for being here. We visited several times. I did not remember your name, but I certainly recognized you when I saw you up there on the screen. So we'll need your help when we start to sell this. So anyway, thank you again.
Thank you.
Committee, any further questions? I wanted to just update the committee that we did receive our marching orders, so to speak, our budget report out today. So we will start, well, actually, we will report out the guardianship program, mortuary arts and pharmacy on 2/7, 2/14 for Veterans Affairs Board of Nursing and KDHE. And we will, and healthcare stabilization, 2/21 state hospitals, and 3/9 Department of Aging and Children and Families. So we've got a pretty aggressive schedule, and so we'll go to work probably the first week in February when KLRD will have our, what do you call it, the BA? Yeah, budget analysis. And we'll go to work as soon as we get that, and we'll get the budget knocked out. So very good. Anything further? We're adjourned.